Hello everyone, welcome to the live session, and we are going to talk today about the oncology EMQs. As you all know, they are the very important part. So oncology is always an issue for all the students. So today we are going to So here we start with our first question, that is the EMQ 1. Right, so you all are ready to answer the questions. So it's your session. So you all are going to participate in it. So I need the volunteers who are going to take up the questions, and then we will do the explanation and the answers to all of these. So here we start. So first, who is going to take up the question? Anybody from the participants who would like to take up? Most of the questions I have taken from the cervical screening and the carcinoma, because cervical carcinoma, because they are the most confusing ones which I feel for the exam. Yes, Dr. Rashim, you are welcome. So you can take up the question.
Thank you, ma'am. A 45-year-old woman has total laparoscopic hysterectomy for heavy menstrual bleeding. She had diathermy loop excision 3 years earlier for CIN3, which was completely excised. The woman did not attend for follow-up, and the hysterectomy sample confirms CIN3, which has been incompletely excised.
Yes. So how we are going to manage this? What is the most appropriate management step for this?
Ma'am, option J, wall smears at 6 and 12 months and then yearly for 9 years.
Okay. So,
right.
Yes. Anybody would like to comment on this? Is it correct, or you want to like make a different, you have a different answer? Okay. So that's great. That's great. Yes. Everybody has a correct answer. That is J. So what is the rule here is that the wall smears, whenever there is an incompletely excised, then we have to follow these patients, right? How we have to follow these patients? Let's just revise quickly that incompletely excised CIN, then at CIN1, we have to do wall sample at 6, 12, and 24 months because that is less serious. CIN2 and 3, that is more abnormal. So we have to keep checking for that. So it is 6 and 12 months followed by 9 annual vault samples. So, can anybody tell me that why we have removed the cervix? So why still we are going for the repeated smear for 9 years?
It's for the vagina.
Ma'am, because vaginal
metaplasia
Yes,
can
very
vein
good.
can
Okay.
also occur because of
Yes,
vein.
because it can lead to the stages in the vaginal
VIN.
epithelium. Yes, so VAIN can be there. So therefore, we are going to do this repeatedly, right? So we have to keep checking. Follow-up should be for either it continues to the 65 years or until 10 years after surgery. This is a multiple times repeated question in exam. And it's a very important recall question, and all these points, all the 2 lines, CIN 1, 2, 3, until what date, all 3 lines are the exam question. And very well answered. Good. Who's going to take up the next one?
Ma'am, I have a question that I have today my evening duty, so I can continue the session. So I'm just
Yes,
asking, do
recording
you
will be
upload
available.
this video
Recording will
later
be available. Don't worry. Right? Yes.
in where? Google Portal?
Now in YouTube, we'll share the YouTube link. Right?
Okay, okay, ma'am. Then will find the video on YouTube.
Yes, yes. Yeah. Okay.
Okay,
So
ma'am.
before
Thank you.
going,
Then
would you
I
like
am
to take up
leaving
this
as I.
question? Before leaving, would you like to take up?
Ma'am, my preparation isn't so good.
Okay. Okay. Then
So,
anybody else who would like to take up? Quick, quick. We have to go ahead with more questions, right? So anybody can volunteer? Nobody needs to volunteer? Okay. 45-year-old woman has total laparoscopic hysterectomy for heavy menstrual bleeding. She had diathermy loop excision 5 years earlier for CIN3, which was completely excised. Subsequently, cytology and high-risk HPV testing have been negative. The hysterectomy sample confirms adenomyosis, but no other abnormality. So, what we are going to do? Yes, I've got two answers, L and A. So I need the explanation, why A and why L. Yes, you can unmute and speak up.
Ma'am, if hysterectomy specimen doesn't have any CIN, is not suggestive of any CIN, then we just have to reassure the patient and no, nothing is required for follow-up.
Okay. So this previous history of CIN3 completely excised, does it make a difference in this question? Of 5 years before, there is a history of
There
CIN3
is,
completely
ma'am, there
excised.
is HPV testing is negative, and
Yes.
cytology
Hmm.
is negative also. So why should we keep doing these smears? The patient has completely excised the CIN.
Hmm.
And when we have to do this smears, we have to take HPV. If HPV is negative, you have to reassure.
Yes, very good. So basically, the thing is, as always, the RCOG does, they add something extra, and then you have to think about the rule, right? So here they have added for your confusion that 5 years earlier it was CIN3. So if you simply look at the question, then whenever there is a CIN3 and fully excised, the next step is to do HR-HPV at 6 months, right? But here they have given you the history 5 years back, and after those 5 years, they have already done the cytology and the HR-HPV test, and that has come up negative. So that part has already been done and it's finished. Now, when you are doing the hysterectomy, then there is no CIN at all. And when there is no CIN, there is no follow-up required. So we are going ahead with the reassure. So if they have given you a simple question of that the patient had undergone hysterectomy for heavy menstrual bleeding and her specimen shows adenomyosis, how would you follow up this patient regarding cytology? So we would have said nothing required because she went for HMB and adenomyosis was there, nothing doing with the cervical screening. So that's it. But to add the confusion, they have given you that 5 years prior she had CIN3. Now, if you just look grossly, then after the CIN3 full excision, we still do HRHPV once at 6 months. But they have given you this 5 years back and they have already done HRHPV negative here, right? So once HRHPV is negative, that all episode is treated. Now she is as good as a normal patient and so she does not need any follow-up. So that's the reassure. So this simple line that has created a trick here. But that's very good that you could answer it very correctly, and A answer is the perfect. I think now there is no confusion about the L or B, like smear at 6 months or smear at 6 months, 12 months, because they were the answers also in the chat box, right?
Yes, ma'am. Yes, ma'am.
Right? Everybody okay with the A, right? Clear?
Yes, ma'am. Yes, ma'am.
So the message is that we have to stick to our rules, our basic rules. We will not go by the distractors which are added by the RCOG. For individuals on routine recall and with no CIN in their hysterectomy specimen, no further vaginal vault sample is required. Completely excised CIN, vaginal vault sample at 6 months. If they have a negative HPV test, they can be discharged. And so completely excised CIN with HR-HPV positive cytology, negative at 6 months, refer to colposcopy. So first thing, as our scenario fixes in the first line. So we are just doing the reassurance. Now coming to the EMQ 3. Who is going to take up this? Anybody can volunteer. See, you guys are answering so well. So just try that. Yes?
Yes, madam, I do it.
Yes, very good. Yes, please go ahead.
A 34-year-old woman attended for a cervical smear 6 months after the diathermy loop excision for CIN2. The cervical sample is reported as showing borderline changes in squamous epithelial cells. Testing for HR-HPV is negative.
Yeah. Yes. What would be the answer?
Refer to colposcopy.
Okay. Okay. So A answer and F answer. Yes. I have two answers in the chat box. What else? Anybody would like to answer extra something? So basically what is happening here is why we are sending this patient to colposcopy? Because of borderline changes?
Yes, ma'am.
Okay. And why we are not sending, why we are doing cytology in 3 years?
Because HR HPV is negative.
Yes.
Ma'am, in this EMQ, maybe it's a little bit old EMQ because now the screening, we start with HR-HPV first, then we do cytology. In this case, HR-HPV is negative. So,
So why cytology was done, right?
Yeah.
But the thing is, like, we have mixed things going on. So in January 2023 paper, January 2024 paper, there were many questions like this, right? So we need to remember these things also. We cannot forget this because January 2024 is not back, right? So it just happened few months back that the questions were there. So we need to know these concepts as well. And one thing I always say that we can never question a question. So when the question is there, we have to go for an appropriate answer, right?
Okay. So here, ma'am, HR-HPV is negative. There is the borderline changes in squamous epithelial cells that are not very high. We can't consider it like a high degree borderline. And the patient have CIN2, which was excised 6 months ago. And maybe we have to repeat HR-HPV.
Okay. So the thing is that, see, whenever we treat, the rule is whenever we treat the CIN, we do test of cure at 6 months, right? This rule is clear. Whenever we treat a CIN, whether it is 2, 3, we do the test of cure at 6 months. So we treated the CIN to 6 months back. So we are at 6 months now and we are doing the test of cure. So in test of cure, we did the HRPV, HRHPV, and that came out to be negative. So when it comes out to be the negative, then what needs to be done further? Nothing.
Recall for
Cytology.
Recall in
No.
3 years, right?
Yes, 36 months, yes.
So simple F option. Repeat cytology in 3 years, nothing else. See the cervical sample that is reported as showing borderline changes in the sample which was removed, right? So now it is HRHPV negative. At 6 months, we stand at HRHPV negative. So there is no need of colposcopy. Colposcopy is only required when the HRHPV is positive and cytology is showing any abnormality. It could be either mild, moderate, borderline, some abnormality in HRHPV positive. Then only we go for the colposcopy, right? So here, because at 6 months we do test of cure and HRHPV is negative, so we will do simple recall. So repeat cytology in 3 years is the correct answer. Fine.
Mom, we repeat cytology, not HPV. As per the cytology was
HRHPV is negative.
It is
yeah.
given as recall in 3 years, right? It
Yes.
is given in the guideline as recall in 3 years. So if you
Right,
look at
yes.
here, we do not have any option of repeat HRHPV at 3 years. So the best option available is repeat cytology in 3 years, right?
Okay, okay, ma'am. Okay.
So is it clear? Why not colposcopy? Yes.
If changes is not borderline and it is a higher degree and HRHPV negative, then still we will do repeat in 3 years.
If at present, see, ideally it should be HRHPV done, and if it is negative, we do not do any cytology. If HRHPV is positive, then we look at the cytology, right? So if any abnormal type of cytology, anything borderline, high grade, low grade, moderate, whatever it is, they all will go for the colposcopy. So at this CIN2, when it is treated, we do recall at 6 months. We do HRHPV. If it is negative, we just send the patient and call after 36 months. HRHPV is positive, we will do the cytology and accordingly. Right?
Okay, madam, clear.
Fine, clear to everyone? Yes?
Then here, because we have treated CIN2 and we are recalling in the 6 months. That's why we are doing like HRHPV. Sometimes when there is a question, they have both like HRHPV is negative and changes are borderline or higher grade. So option like send to call, like there is no like they were treated for the CIN2 or 3.
So they were not treated patients. They were the initial patients. When you were diagnosing them, the condition, in that case, if it is a severe dyskaryosis and HRHPV is negative, then also we will go for the colposcopy, right? Because if it is a severe dyskaryosis. Ideally, with the present system, with HRHPV negative, we should not go for the cytology. But that confusion is why creating there, because sometimes we are going to the old pattern and sometimes we are in the new pattern. So some questions are coming from the old pattern and some are coming from the new pattern. So that is why this confusion. So the question now which you are asking is severe dyskaryosis with HRHPV negative. In present scenario, if the HRHPV is negative, we will not go for cytology, right? So as per the new guideline, that question does not hold true. So we have to go back and search the answer from the old guideline. So in old guideline, severe dyskaryosis, HRHPV is negative, we still have to go for colposcopy. Right?
Okay.
Clear now?
But in this scenario, like if it was treated for the CIN2, it was treated, so here we will not go for the colposcopy.
No, we have to just go for the HRHPV, and if it is negative, simple recall in 36 months. And if it is positive, we will go for the further cytology and colposcopy. Right? Clear?
Yes, ma'am.
Confusion okay? Right. Okay, so who is going to take up the next one? Yes, quick. The quicker you take, we will be able to cover more questions. Shall I call? Anybody? Dr. Tina? Yes.
Yes.
Yeah. Start. Not audible. 75-year-old woman presents with a 3-month history of vulval discomfort. Wide local excision of a 12 mm lesion is undertaken. Histology confirms a well-differentiated squamous cell carcinoma with 14 mm margins after tissue fixation and 1.3 mm maximum depth of invasion. So now, what we are going to do? Anybody? Nobody? What is the stage of the disease?
1A1.
Okay, so invasion depth is 1.3 mm.
A2, yes.
Yes.
1A2.
1A2, correct.
1A2, yes.
1A2 is correct. So now when we say 1A2, what we need to do, already wide local excision has been done. So what do we need to add something or it's okay?
Groin node dissection,
No
ma'am.
dissection.
Yes,
Ipsilateral one.
yes, we need groin node dissection here because 1A1, we don't need groin node dissection, but 1A2, we need groin node dissections. F is the correct answer. So 1A, we just do the wide local excision without groin node dissection, and lesions are, the depth of invasion is less than or equal to 1 mm. As it goes more than 1 mm, we go into the stage 1A, 1B rather. So basically, here exam point is groin node dissection can be omitted in patients with varicose carcinoma, basal cell carcinoma, melanoma, and patients with FIGO stage 1A tumors. Now here it is 1B, right? Here it is 1B. So we are in the groin node dissection, right? So here it is stage 1B. So we choose the groin node dissection. How do we choose whether it is going to be the unilateral groin node dissection or bilateral groin node dissection?
If it's central, it's bilateral. If it's unilateral, if it's only single, one side, then it's unilateral.
Good.
If the tumor is more than 4 centimeters, it will be considered as a median one.
Or somebody has joined from 2. Okay, so be careful. So basically, that's okay. That if it is a central tumor, it's going to be it is going to be bilateral. If it is on the lateral sides, it's going to be the unilateral. This is an important exam point and often tested in exams. Groin node dissection can be omitted in patients with varicose carcinoma, basal cell carcinoma, melanoma, and patients with FIGO stage 1A tumors. Now coming to the next question. Who is going to take up this? Easy question. You just have to read the question. Why so afraid?
I'll do, ma'am.
Yeah.
A healthy 42-year-old woman has cervical screening 12 months after an initial test, which was positive for HR-HPV with negative cytology. The HR-HPV test remains positive and cytology is borderline.
Yes. Now what? Now what
Refer
is
to colposcopy.
Refer for colposcopy.
Yes. Everybody agreeing with that? Any other answer? What is
Yes.
the rule? Why we are doing so?
Refer to colposcopy.
What is the rule?
Because there is two HR-HPV positive, madam.
And cytology is borderline.
Yes.
Cytology
Absolutely.
comes.
Because HR-HPV positive and cytology abnormal. It's borderline. Any abnormality in the cytology with HR-HPV positive, we have to go for the
Colposcopy.
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 Yes. So therefore, colposcopy, refer to colposcopy is the correct answer, right? So here, one test positive, then second positive, and now cytology is also borderline. So we have to go for the colposcopy. At any point, wherever the HR-HPV is positive and cytology is abnormal, we will go for refer to colposcopy. Now, coming to the next question. Anybody wants to take, or shall I go ahead? Yes, anyone? Okay, so I'll go ahead. Healthy 67-year-old woman presents with a 3-month history of postcoital bleeding. Speculum examination identifies a 5 mm lesion on the ectocervix. Biopsy confirms a squamous cell carcinoma with a 3 mm depth of invasion. There is no lymphovascular space invasion. Choose the most appropriate management option.
See, ma'am.
Stage
Let's
1A1. This stage 1A1. So
1A2 because 3 millimeters it goes with the A2, no?
no, it's
Less than 3 mm is stage 1A1.
1A1.
yes, yes.
3 mm to 5
Stage
mm
1A2.
is 1A2.
Stage 1A2.
So what we are going to do in 1A2?
Radical hysterectomy with pelvic lymphadenectomy.
Radical hysterectomy plus pelvic lymphadenectomy. E, ma'am.
Yes.
Why not let's, ma'am?
Why not?
There is no lymphovascular space invasion.
Let's.
Leads. Leads is the answer in stage 1A1.
A1.
Okay. So that is only up to 1A1. So not to be used in 1A2. From 1A2 onwards, it is radical hysterectomy, right? So this is stage 1A2. So E is the correct answer. Radical hysterectomy, bilateral pelvic lymphadenectomy, external pelvic beam pelvic radiotherapy, that can be used. Okay. Now coming to the next one. So 38-year-old woman presents with the 3-day history of blood-stained vaginal discharge at 30 weeks gestation. Speculum examination identifies a 1 centimeter lesion on the cervix. Colposcopy identifies a 12 mm area of dysplasia confined to the cervix, and biopsy confirms a squamous cell carcinoma. MRI scan confirms a 12 mm lesion confined to the cervix with no pelvic or para-aortic lymphadenopathy. Now, what is happening here?
1B2. 1B1.
So, what we need to do in 1B1?
Cesarean section plus radical hysterectomy plus pelvic lymphadenectomy.
Bilateral pelvic lymphadenectomy.
G, ma'am.
J is cesarean section plus radical hysterectomy 6 weeks later. So you do the cesarean now and do hysterectomy 6 weeks later, or you can do both simultaneously. And if you are doing simultaneously, then roll off lymphadenectomy. So these are the 3 things asked in this question.
G, not J. Okay, ma'am.
G. So everyone agrees with G?
G, yes, ma'am.
Yes. When we do not treat, then we can do the early cesarean section after 12 weeks, and we can do the radical hysterectomy simultaneously. If we treat the tumor in the pregnancy, then in that case, we can take up the pregnancy beyond 36 weeks. So, but here we have not treated the tumor. So cesarean section plus radical hysterectomy plus pelvic lymphadenectomy is the correct answer. That is the G option. That's the perfect answer. Right, so CS cervix with pregnancy is again one of the very, very favorite topic of RCOG, right? So it is very, very important that we should know these topics very well. So stage 1B1 cervical cancer at a later stage in their pregnancies, delivery should be by cesarean section once viability has been achieved, immediately followed by the radical hysterectomy and pelvic lymphadenectomy, right? Now coming to next question. So healthy 67-year-old woman presents with a 6 months history of postmenopausal bleeding. Clinical examination identifies an ulcerated lesion on the cervix extending into the lower third of the vagina, and the biopsy confirms squamous cell carcinoma. Now, what are we dealing with?
Stage 3A.
3A. 3A, yes.
So
Okay.
surgery is not an option.
So, what is the correct option?
G, ma'am. Chemotherapy plus
Chemo, ICT and EBRT.
plus EBRT.
G, ma'am. Yeah.
G, ma'am.
Everyone agrees with G, right?
Yes, ma'am.
Perfect. So G is the correct answer. Yes, all answers in the chat box are correct, and that's perfect. So chemotherapy plus intracavitary and external beam radiotherapy. If you know the stage, if you can classify the stage properly, then your answer is going to be perfectly well. And I'm really happy that you all know the rules we have discussed in our class. You are able to follow them and apply them to the questions. So you can see how effective the rules are. If you can just follow the rules, your answers will be correct. Happy for all of you. So this is answer G. So here the tumor invades the pelvic side wall or the lower third of the vagina or causes the hydronephrosis or non-functioning kidney. Then this is the stage 3, and the treatment options are radiotherapy plus chemotherapy, intracavitary radiotherapy and external beam radiotherapy to the pelvis combined with chemo can be the correct option. Okay. Anybody still want to go with any question? We have few more. So you all can try. Yes?
I'll go.
Anybody? Yeah.
A 38-year-old woman with dysfunctional uterine bleeding has laparoscopic total hysterectomy with conservation of the ovaries. Histological examination identifies a squamous cell carcinoma of the cervix measuring 2.5 into 4 millimeters with a depth of invasion of 1.5 millimeters, which is 1A1 only.
So what is the correct answer? Depth of invasion is 1.5 mm. See, lateral, we know that lateral extent does not matter anymore, right?
Yes, sir.
So it is the depth.
Nothing to be done. She has undergone laparoscopic total hysterectomy. Conservation of the ovaries is done. So no additional treatment is required.
Everybody agrees? Any other answer?
No.
No treatment.
No.
So yes, no treatment.
H.
Yes.
Ma'am, maybe H. BSO plus ammentectomy because of the size.
Is there any role of omentectomy or salpingo-oophorectomy in CS cervix?
No role.
Not ovarian, ma'am. It is CS.
No, ma'am.
It's not ovarian. So we have to, the message
Besides
is
this,
that
38 years old.
So whatever, like 38 years, why would like to do salpingo-oophorectomy, and what is the role going to be for the omentectomy? We take the sample of omentum, that is omental biopsies, when we are in the staging laparotomy for ovarian carcinoma.
Yes.
Right? For nothing else. We don't do it for vulvar. We don't do it for endometrial, for nothing. We do it. Omental biopsies are part of staging laparotomy done for ovarian carcinoma. Clear? Fine. No other cancers. And here we are dealing with the CS cervix. So no role of omentum, right? Bilateral salpingo-oophorectomy at 38 years, no role. right? If the patient is 49, maybe you would like to go ahead with that, but not at 38, right? So H is not the correct answer and D is the perfect answer because already she has undergone the laparoscopic total hysterectomy. So that's already done. So we don't want to do anything next, right?
Yes, ma'am.
Fine? Oh, good.
Yes.
Yes,
Okay.
ma'am.
Coming to next question, anybody who would like to read that? See why I'm telling you to read it? Because even the proper reading of question and highlighting where you have to stop, what points you have to see, that is also a part of solving the questions, right? So in exam, you have a highlighter also. How you can use the highlighter in the exam? So just we can see that also. So now if I tell you that what is the age? So 37-year-old woman we are talking about. Then we are talking about the total abdominal hysterectomy. She has already had the total abdominal hysterectomy. Cervix is macroscopically normal, right? Now, what happens when we see this specimen under the microscope? We found that the lesion is there with the invasion of 3 mm depth. Now, what stage it is going to be? These
Ma'am, can
things
you?
are
182.
182.
182.
2.
A2.
right.
3 mm. Diameter 3 mm.
We don't have to
J.
look by the diameter. This is simply the stage 1 cervical cancer.
A.
Right? So this is simply the stage 1 cervical cancer. So you can use your highlighter in your exams also, right? You can just point out
Okay.
what is important because there are long questions. If you use your highlighter, then you can just mark it what is important and then it becomes a single line which you can just read and answer your question without any confusion, right? Last time, many of the students were actually asking that there was highlighter, what we can do with that. So this is the way you can use your highlighters. Okay, so here comes the next question. 37-year-old woman has cervical screening 12 months after an initial test, which was positive for HRHPV with inadequate cytology. The HRHPV test remains positive, but the cytology is now negative. She smokes 10 to 15 cigarettes per day. So now she is, HRHPV is positive, but cytology is negative. Now what we can do for her?
Ma'am,
Cytology and HRHPV
we,
on 12 months.
We call in 12 months.
ma'am, we
H,
can call her
ma'am.
after 12 months.
H.
Because now, since we know that HRHPV is positive, we want to see the progression of the disease.
So
We will see
So
whenever,
in 12 months.
We
yes,
will
so
see if the
whenever,
HPV will goes alone without treatment, and it can goes alone after 2 years of the.
yes.
I mean, yeah.
Okay, so the rule is, first we talked about whenever we treat the patient for CIN, we do test of cure at 6 months. So we do HRHPV at 6 months. Other rule is that when we do not treat anything, then we repeat it in 12 months, right? Because why after treatment we are doing the early recall and why without treatment we are doing the late recall?
Because we want to see the cytology later on. Like, if it is CIN1, it's supposed to, it usually goes down.
Because if we treat, because there is a cancer out there, so we have to just look if HPV is there. If it's not, there is no cancer, we just see if it will goes alone, this HPV.
Okay, so partly correct. I'll just make it slightly better. See, when we treat, we have removed the lesion, right? We have removed the complete lesion. We have just removed it. So ideally, our HRHPV should now be negative. If it is still there, then we are particular about it and we want to see whether it is going bad, further bad, right? But when we have not treated the patient, then we do not expect it to clear in 6 months because it takes time to clear because it is being cleared by the body. It is by the natural immune mechanism it is being cleared. So it takes time. So if we review in 6 months, we can't get any good information there. So we try to do it after 12 months. If at all, then 12 months also positive, we still give 12 months more, right? So basically, it is by the natural mechanism that it is being removed. While when we, yes, HPV resolves in 2 years. This is correct. So that is where we are looking at 12 months, right? But when we treat, we have removed it. So ideally, it should not be there. If our treatment is, we have done the complete treatment, ideally, it should not be there. But if it is there, that means we want to see whether any bad thing is happening, right? Clear? Why we do this? Okay, thank you, Divya. It's good to know that it's helpful to you. Okay. Okay, fine. So this is clear. Answer is D. Okay, so now see how they fool you. They have given you stop smoking here. So if a person looks at smokes 10 to 15 cigarettes, then you can immediately think about this
It's a
option
distract.
or yes, this option, right? But why not H? Okay. Stop smoking, then cytology HRHPV 12 months later. But actually, first we will do HRHPV and it is not like stop smoking and then do, right? We have to do in 12 months anyway. So therefore, D is the better answer as compared to H. Okay. So that's how the answer is. Okay. So let's go forward. This is HRHPV positive results and negative cytology. HPV test is repeated at 12 months. If HPV testing is negative at 12 months, we'll send the patient to routine recall. If HRHPV remains positive, cytology is negative at 12 months, we call the patient at 12 months. Then when we call second time, now it is 24 months from the first one. Because first we called at 12 months, then we again called at 12 months. So total it becomes 24 months. So once it is negative at 24 months, we will send the patient to routine recall. Right? So this is how you have to deal with the scenarios of HRHPV positive results and negative cytology. Fine? Any confusion? Okay with everyone?
No, ma'am.
Good. Okay. So I think this is the last question for the day. So 30-year-old woman has a cervical smear showing severe dyskaryosis. Colposcopy identifies a 5 mm lesion on the ectocervix. Punch biopsy confirms a squamous cell carcinoma with the depth of invasion 4.5 mm and there is no invasion of lymphovascular space. The woman has completed her family. Now what?
Radical hysterectomy, pelvic lymphadenectomy.
Bilateral pelvic. Ma'am, E.
E. Okay. What is the stage here? If we need to stage.
1A2.
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 Okay. So it is between 3 to 5 mm. So that's perfect. This is 1A2. And when it is 1A2, we have to do the radical hysterectomy and pelvic lymphadenectomy. Yes. So E is the perfect answer. That's it. That was a quick, short session about the cervical cancers and screening. I hope it was a good revision for all of you. And we can do such small sessions further also, focusing on any particular topics. If you want to discuss any particular topic, you can let me know. And this video will be posted on the YouTube. It's actually going on YouTube live also. So it will be there and you can just leave your comment. How did you like this session? And if you want to discuss any particular topic, you can also leave the topic there. We can just do these quick focus sessions for you and it will be helpful, right? So anything you guys want to say?
Ma'am would like to have more questions on this cancer in pregnancy.
Cervical screening cancer.
Yeah, sure.
In pregnancy,
we can have
ma'am.
another session also. Thank you, Divya. Thank you, Dr. Malika. Yes. So we can do that. We will certainly plan it very soon. Any other topics which you need? Like I can think of emergency contraception, which is also important topic. We can
Ma'am, missed
do
pills wala, that is
Missed pills,
that
ma'am.
missed pills
missed
thing.
pills.
We
Yes,
get confused.
yes, unscheduled bleeding, missed pills. So we can do sessions on that. You can just leave your comments in the comment box, and that would be a great thing. And all those new people who have joined here today, you can formulate the rules with us and get your success in 70% less study time. And if you are interested, then here are the details. Right?
Ma'am,
Thank you so much. Yes.
Excuse me, ma'am. Sorry. I just wanted to know that IBS, I get very confused in diagnosing IBS and that Rome criteria and all.
So no need to go into those much details. Important is you need to remember that alternating diarrhea, constipation, any symptoms which are occurring more than 4 times in a month and persisting for quite a long period of time, like 6 months to 1 year, and particularly in the postmenopausal women, these symptoms occurring for the first time. In your context, you will have IBS, 2 types of questions. One, there will be in the chronic pelvic pain, and the other will be in the context of postmenopausal patient coming up with the symptoms and being diagnosed as ovarian carcinoma. So these are the 2 cases where you will find IBS. So if you find it in the chronic pelvic pain, then the answer is going to be mebaverine. And if you are going to find it in the ovarian cancer, then you have to go ahead with the CA-125. That's simple, right? So keep your rules simple and it will help you in answering the exams, right?
Mom, please.
Yeah.
Mom, what was the answer for the previous question? Because I got disconnected, please.
Okay, so it was radical hysterectomy and pelvic lymphadenectomy. Right?
Even
because
she
the
is
depth of lesion is between 3 to 5 mm.
Yes,
so
even she is 30 years, Mom.
So what? We have to treat according to stage.
Okay.
Because if at all they have mentioned that she wants a fertility preserving thing, then we would have gone for the radical trachelectomy.
Yeah. This is what
but
I
they
was.
have given that the woman has completed her family. So we are going for the radical hysterectomy. If this sentence, the woman has completed her family, this is replaced by like the woman wants to have more children, then we would have gone for the trachelectomy. Right? She was the ideal patient for trachelectomy.
Okay. Mom, trachelectomy, we go till 1B?
Yes, 2 centimeter.
Okay. Thank you, Mom.
Okay. Bye-bye.
Thank you.
Thanks
Bye
everyone.
bye. Thank you.
Have a
Thank
nice
you, ma'am.
weekend.
Thank you so much.
Meet again. Thank you.